At 11:47 p.m., the emergency room doors burst wide open as paramedics began bringing in the first casualties from the downtown explosion. Within minutes, 22 injured people filled every available space at St. Mary's Hospital. Nurses were overwhelmed, doctors were shouting orders, chaos was everywhere. But emergency room nurse Amanda Torres did something different. While others panicked, she moved through the chaos with military precision, organizing patients with a system no one had ever seen before. "Critical red zone, urgent yellow, minor green," she called out, directing each patient to specific areas with calm authority that cut through the noise. "Amanda, where did you learn that triage method?" asked Dr. Peterson, watching her work. "Different places," Amanda replied quietly, continuing her systematic approach. But what Amanda did in the next 3 hours would reveal a secret she had kept hidden for 8 years, because her hands moved like someone who had treated combat wounds under enemy fire. And that organized chaos management wasn't something they taught in nursing school. Welcome to Hidden Legends. Before we continue with this incredible story, tell us in the comments which city you're watching from, and if you believe stories like this deserve to be told, hit that subscribe button. Amanda Torres had been working as an emergency room nurse at St. Mary's Hospital for 6 years. At 34, she was reliable, always on duty with precise timing. Together with the night shift team of Dr. Sarah Peterson, nurse coordinator Mark Jenkins, and other nurses, they would respond to 15 to 20 emergency cases daily. "Amanda is one of our most composed nurses," said Emergency Department Director Dr. Peterson. "Calm under intense pressure, advanced medical knowledge, never loses control. Patients feel safe with her." But Amanda's ability to stay calm under intense pressure came from places very different from a normal emergency room nurse's experience. Her routine as an emergency room nurse was always the same. Shifts started at 7 p.m., ended at 7 a.m. Heart attacks, traffic accidents, violence incidents, drug overdoses, standard emergency medicine cases. Amanda remained methodical and effective in every situation. Mark found Amanda's behavior during crisis moments different. "Amanda, how do you stay so systematic during multiple casualty events?" he would ask. "Experience," Amanda would say quietly. "There should be a system for every situation." This experience came from a 10-year career as a Delta Force combat medic. Combat medical support in special operations, mass casualty incidents, emergency surgery under enemy fire. Amanda had conducted operations in the world's most dangerous regions. Amanda Torres' real story began 16 years ago. She had joined the military at 18. But why? It wasn't family pressure. It wasn't economic necessity. It was something completely different. In her childhood in Chicago, Amanda had witnessed urban violence, gang wars, armed attacks, mass casualty events. "I want to save people in moments of chaos," she had told the military recruiter. After basic training, Amanda received Medical Corps, then Airborne, Ranger, and eventually Delta Force selection. She showed exceptional physical and mental performance. She passed the Combat Medical Specialist selection process. The Delta Force Combat Medic selection was the military's toughest training. Psychological evaluation, extreme physical tests, advanced medical competency exams. Amanda ranked in the top 1% among female candidates. Her first assignment was Afghanistan. Medical support in Delta Force operations, battlefield surgery, hostile environment medical evacuation. During 2.5 years of duty, she conducted over 60 critical life-saving operations. Her second assignment was Iraq. Urban warfare medical support, mass casualty response after IED attacks, multiple casualty incident management. Amanda's specialty was medical organization within extreme chaos. Her third assignment was classified special operations, Black Ops medical support, high-value target extraction medical coverage, international hostage rescue medical operations. Amanda's most critical and dangerous missions occurred during this period. Amanda's Delta Force training wasn't just combat. Advanced tactical medicine, mass casualty incident management, battlefield surgery, extreme stress medical operations, specialized skills. A Delta Force medic must be a complete medical warrior. said Training Commander Colonel Martinez. Battlefield surgeon, tactical medic, crisis commander, life-death decisions under multiple casualties. Amanda had completely internalized this mentality. Advanced surgical procedures in combat zones, maximum patient rescue with limited resources, medical leadership in high-stress environments. Her medical knowledge was at attending physician level. The most critical training was mass casualty response, bomb attacks, building collapse, multiple trauma scenarios. Amanda had learned to handle 30 to 40 casualties simultaneously. She had specifically received battlefield triage training, maximum lives saved with limited time and resources, color-coded priority systems, rapid assessment protocols, resource allocation under pressure. These skills would be incredibly valuable in Amanda's civilian emergency medicine. After 10 years of active duty, Amanda made the decision to retire. Combat PTSD symptoms, desire for normal life, commitment to peaceful medical service. She transitioned to emergency medical services. "Why are you leaving Delta Force?" her special operations commander had asked. "Because I want to continue life-saving in a civilian environment. Same mission, different battlefield." During nursing school, Amanda was overqualified. Advanced medical knowledge, crisis leadership experience, trauma management expertise. But instructors hadn't asked detailed military background questions. "I've always wanted to work in emergency medicine," Amanda had said, "helping people in critical moments." Emergency room nursing was a perfect fit. The hospital structure felt familiar to Amanda. Emergency protocols, life-death decisions, team coordination under pressure. When St. Mary's Hospital hired her, Amanda was an exceptional employee. Clinical competence, crisis calmness, advanced medical skills. But nobody knew her extraordinary military background. On Friday night, November 18th, Amanda was on her normal night shift. With Dr. Peterson and the team, they had responded to 8 routine cases: chest pain, car accident, domestic violence, drug overdose, elderly fall, psychiatric emergency, minor burns, appendicitis, standard emergency room operations. The shift was passing quietly, normal patient flow toward the weekend. By 11:30 p.m., most patients had been discharged or admitted. "Peaceful night, Amanda," said Mark, updating patient charts. "Early finish possible. Friday night usually crazy, but tonight calm." "We should always be prepared," said Amanda. "Big emergencies come after quiet moments." This instinct came from 10 years of Delta Force experience. In combat zones, the calm before the storm was always dangerous. At 11:47 p.m., the hospital communication system alarm rang. The dispatch center broadcast an urgent message. "All units, mass casualty incident downtown. Explosion at Metro Plaza, multiple casualties, unknown number, all emergency services responding. St. Mary's Hospital, prepare for multiple trauma patients." Dr. Peterson immediately went into command mode. "Activate mass casualty protocol, all available staff to ER. Cancel non-essential procedures." But Amanda was already in motion. Delta Force training had automatically engaged. Mass casualty response protocols, resource preparation, area organization. "Mark, prepare triage supplies, color-coded tags, emergency medications, surgical equipment standby. Extra 4 access kits ready." Mark was surprised by Amanda's immediate detailed preparations. "Amanda, do you have mass casualty experience?" "Basic training," said Amanda, but her movements were military precision. At 11:52 p.m., the first ambulance arrived. Paramedics rushed in a severe blast injury patient, multiple lacerations, possible internal bleeding, altered consciousness. "Trauma Bay 1, directed Dr. Peterson. But suddenly, more ambulances arrived. 2, 3, 4, 5 ambulances simultaneously. Paramedics streaming in 22 patients with various injury levels. The ER was instantly overcrowded. Chaos erupted. Nurses running everywhere, patients crying, family members panicking, doctors shouting orders. Normal hospital protocols were breaking down under the volume. Amanda looked around, assessed the situation, and immediately her military training activated. "Dr. Peterson!" Amanda's voice cut through the chaos with authority none had heard before. "We need to implement mass casualty triage protocol. Current approach is overwhelming our capacity." Dr. Peterson looked surprised. Amanda, what do you suggest? Color-coded zone establishment, critical red zone in trauma bays, urgent yellow zone in treatment rooms, minor green zone in waiting area, priority-based resource allocation. Amanda started directing patients before waiting for approval. Her command presence was immediately noticeable. Critical abdominal injury to red zone, conscious head laceration to yellow zone, walking wounded to green zone. Nurses automatically began following Amanda's directions. Her organization system made sense. Chaos was reducing. Amanda made rapid assessments, evaluating each patient. Her medical evaluations were extraordinarily fast, yet thorough. Patient 1. Penetrating chest trauma, possible pneumothorax. Priority 1, trauma bay immediately. Patient 2, severe burns 30% body surface, stable vitals. Priority 2, burn treatment area. Patient 3, multiple fractures, no life threat. Priority 3, orthopedic evaluation. Her assessment speed and accuracy impressed everyone watching. This wasn't standard nursing triage. This was military-level medical evaluation. Amanda, said Dr. Peterson, watching her work, your triage assessment is incredibly detailed. Where did you learn this system? Different places, Amanda replied, continuing systematic organization. Amanda approached critical patients. Advanced medical interventions began beyond normal nursing scope. Critical patient with chest trauma. Amanda performed rapid needle decompression when pneumothorax was evident. This was an emergency physician procedure, not a nursing intervention. Severe bleeding patient. Amanda applied pressure point control, tourniquet application, IV access establishment with military precision. Her technique was professional combat medic level. Unconscious head trauma. Amanda conducted neurological assessment, Glasgow Coma Scale evaluation, cervical spine stabilization, advanced trauma evaluation protocols. Mark watched Amanda work with amazement. Amanda, your medical interventions are very advanced. Nursing school doesn't provide this level of training. Amanda paused her work, looked at Mark. Decision moment. You're right, Mark, said Amanda. Nursing school didn't teach me this. Mark and Dr. Peterson were waiting. I'm a former Delta Force combat medic. Sergeant First Class Amanda Torres, retired. 10 years special operations, 4 deployments, 3 major conflicts. Complete silence in the emergency room. Other staff members nearby heard and stopped working. Delta Force? Said Dr. Peterson in amazement. You were a special operations medical specialist? 10 years? Battlefield surgery, mass casualty management, combat trauma medicine, tactical medical operations. Amanda continued treating patients while explaining. Every medical intervention was perfect, every assessment professional. Why are you doing emergency room nursing? Amanda's expression became serious. In 2017, on an operation in Mosul, a civilian shelter was bombed, 28 children, 15 adults. I couldn't save them all. Silence. Since that day, I decided to use my medical skills in a civilian setting, to protect innocent people, save families. Over the next 2 hours, Amanda created a medical miracle. All 22 patients were treated, stabilized, and received appropriate care. Critical cases received surgical intervention, urgent cases comprehensive treatment, minor cases proper evaluation and discharge. But most impressive was the organization. Amanda's triage system created perfect patient flow, optimal resource utilization, excellent staff coordination. Amanda, this organization is incredible, said Dr. Peterson while treating the final patient. 0 patient deaths, all received appropriate care level. Team effort, said Amanda humbly. Team effort? You single-handedly organized the mass casualty response. Under standard protocols, some patients probably would have been lost. Emergency department staff gathered around Amanda. Recognition and respect were obvious in their eyes. The next day, hospital administration learned of Amanda's background. An emergency meeting was called. Amanda, why did you never mention your military experience? Asked Chief of Staff Dr. Williams. It wasn't relevant. I'm an emergency room nurse now. Not relevant? You have advanced trauma training, crisis leadership experience, mass casualty expertise. Dr. Williams continued, Amanda, We want to offer you a promotion: emergency department supervisor, trauma coordinator, disaster response specialist. Amanda considered. I like direct patient care, hands-on medical service, immediate help. But your skills could benefit the entire department: training programs, protocol development, emergency preparedness coordination. Amanda is now recognized as both senior emergency nurse and training director. Her influence extends far beyond St. Mary's Hospital. The emergency medicine protocols she developed have become standard practice at multiple hospitals. The training programs she created have been replicated nationally. The military taught me battlefield medicine. Civilian service taught me compassionate patient care. Both create a complete medical professional. Mass casualty survivors express gratitude when they see Amanda. You saved lives that night. Professional competence, calm leadership made the difference. Amanda's story is included as a case study in medical textbooks, a perfect example of military to civilian expertise transfer. Amanda Torres' story isn't about heroism. It's about service commitment, continuity, peaceful application of expertise. From Delta Force to emergency room nursing, from battlefield medicine to civilian healthcare, from tactical operations to community medical service. Always serving. The military trained me in crisis medicine. Civilian practice trained me in patient-centered care. Both are essential for optimal medical service. Emergency patients feel confidence when they see Amanda. Real medical warriors change their forms of service, but the healing commitment never ends. Amanda's dedication that night was the civilian application of Delta Force training, military medical expertise, perfectly applied in a hospital emergency. I'm no longer a soldier, but the medical service spirit never stops. The mission continues. The battlefield changes. The community will appreciate in the future. Medical excellence takes many forms. So I ask you, have you ever met military medical veterans quietly serving in your healthcare community? Hidden combat medical backgrounds silently contributing in civilian emergency medicine? Share in the comments. Because at Hidden Legends, we know that the greatest medical professionals often serve in the most challenging roles. If this story moved you, share it, subscribe, and help these important veteran medical stories continue. We'll see you in the next legend. And remember, next time you see an emergency room, ambulance service, or trauma center, there might be military medical backgrounds you're unaware of. Real heroes change their forms of medical service, but the healing spirit never ends.